So the title of my presentation is Initial Treatment Strategy, and it will better cover the journey of a patient when we think about the diagnosis of amyloidosis. Here are my disclosures. So I will not repeat the pathogeny of amyloidosis, just to say that the light chains that are originated from abnormal plasma cells will have special physicochemical properties that will aggregate them together, and this aggregate will be very toxic for the cells, particularly for the cardiac myocytes, and also with time they will aggregate together, making very long fibrils that will deposit in the organs because they will not be able to stay in the bloodstream anymore. And so amyloidosis is mainly driven by circulating light chain aggregates and amyloid deposits. You know that any organs, maybe with the exception of the brain, can be involved by AL amyloidosis deposition, and the clinical presentation will depend on the pattern of organ involvement. But in some cases, symptoms will be very vague, like fatigue or weakness of weight loss. Most of the time, it's the heart and the kidneys that are affected. So when you think about amyloidosis, maybe because you have some red flags like heart failure with a preserved ejection fraction, of a nephrotic range proteinuria, of a polyneuropathy in the absence of diabetes, of if you have MGUS with an atypical presentation, you will think maybe of amyloidosis. But then, in order to recognize this disease, you will have to think about the three pillars that will lead you to diagnosis. And as you can see, I've chosen this emblematic building of Brussels for the one of you who want to visit our city. So the first step is biopsy. The diagnosis of AL amyloidosis is the recognition of congruent deposition on a biopsy. You have here a kidney biopsy, and you can really see this red staining that represents the presence of congruent. And as you know, when you apply polarized light, you will have the appearance of this apple green staining that is characteristic of amyloid deposition. The second thing you will have to do is typing, and you clearly see here on this piece of this slice of nephrologic biopsy, you clearly see the staining for the lambda chain when you see that there is no staining for the kappa chain. Why is it so important? It's important because there are approximately 40 different proteins that are involved in amyloid precursors in humans. So 40 different proteins that can give you that can lead you to the diagnosis of amyloidosis. But of course, the typing is critical because the therapy will be type specific. So that means that when you have a congruent staining on a biopsy, and you have a MGUS in the bloodstream of any abnormal plasma cell in the bone marrow, it doesn't mean that you have AL amyloidosis. So, in fact, we know that in wild-type amyloidosis, ATTR amyloidosis, approximately 30% of patients have also a MGUS, and it's not very special to say that, knowing that MGUS is very frequent in the elderly population. So typing of amyloidosis is of primary importance, and we use a lot of different kinds of methods that were explained earlier in this meeting. Then, if you have the diagnosis of AL amyloidosis, of course you have to investigate the clone that is responsible for the disease. As the patient of myeloma, for instance, most of the case it's not the case, but till 10-15% of patients will have we will be diagnosed with amyloidosis and myeloma, but usually the burden, plasma cell burden is low and the proliferation rate is low. And that has some impact on the way you will treat your patient later on. The other point is to get some information about the biology and the genetic of the disease. As this was already said in the morning, the presence of translocation 1114 is there in almost 50% of patients. It has also some implication in terms of therapeutics, and the one who are said to be a bad prognosis in myeloma, such as 414 and deletion 7p, are less frequent in AL amyloidosis. The next point will be to investigate organ damage, and so it's the only way to know where the deposits are, in fact, to the patient. When you have the diagnosis of AL amyloidosis, the next state is staging. Why is it important? Because, as it was already said in the morning, at diagnosis, up to 70% of patients have advanced cardiac disease. And unfortunately, cardiac involvement is the main determinant of outcome in AL amyloidosis. On this slide, what you can see, if you look at the cumulative incidence of the causes of death across the course of disease, you clearly see that cardiac failure and sudden unexpected deaths are in the front, far before infection of renal failure. So it's important to stage the patient, and the main determinant, as already said, with the single most important prognostic factor is cardiac involvement. That means that you will realize how sick your patient is. Well, I put here the classification of a Mayo 2004 and Mayo 2012, knowing that we're using NT-proBNP or even BNP and troponin. In addition, with the free light chain, you can stage the patient. You hear also that this classification are moving, that with the occurrence of new treatments like daratumumab and Velcade, probably the delta free light chain has less impact in this classification of this staging. When you have the diagnosis, you have staged your patient, it's time to speak about therapy, and it's also important to remind that there are 3 pillars in the treatment of patients with AL amyloidosis. First is early recognition, second is anti-plasma cell therapy, and third, but certainly not the last, supportive care. Well, we speak about early recognition. We have to acknowledge the fact that AL amyloidosis is still a rare disease, underdiagnosed. Symptoms, as already said, are not specific. There are multiple presentations, many medical entry doors, and of course, as already said, we need a rapid tissue diagnosis. AL is uncommon. It's around 10 cases per million population, and as you can see, it's quite less frequent compared to multiple myeloma, even if it's certainly underdiagnosed. Symptoms are not specific. It was already covered. I already mentioned the fact that the patient can enter the disease with constitutional symptoms that are absolutely not specific. And if you look on the right part of the slides to periorbital purpura and macroglossia, who are more typical of the disease, these occur only between 10 and 15% of patients. In addition, there are many medical entry doors. People usually will consult more than 5 physicians before getting to a diagnosis. And on the left part of the slide, you clearly see that only a third of patients will have a diagnosis within 6 months, and more than a quarter of them will have to wait between 2 and 3 years or more to get a diagnosis. So even if a patient has an MGUS and is followed by an hematologist, we can miss the diagnosis. So there is any way to say that early diagnosis means less organ failure because less deposition of fibrils in the body. And so the only thing we can do is making awareness of the disease. And in addition, if patients have an MGUS of a smoldering myeloma with an abnormal free light chain ratio, try to evaluate him every year using two things that are not so difficult to assess, albuminuria and NT-proBNP. The second point is AL amyloidosis therapy. What is the best treatment? Well, probably the best treatment is the one that will achieve the deepest response in the shortest time with the minimal risk, and that was already covered in the morning. So I borrowed this slide from Dr. Milani, and you clearly see that if we want to have a good response, the first thing to get is an hematological response. So we need to have a rapid free light chain normalization that is critical if you want to have an organ response and modify the overall survival. And on the right part of the slides, you clearly see the benefit not only to have hematological response, but also to get organ response in order to prolong survival. So that means also that we have to use response criteria, and that was, I think, enough cover during this morning. The first goal is to assess an hematology, to have achieve an hematological response, and you will also that these criteria are evolving over time, and now it's the best response will be assessed with the delta free light chain is less than 20 or more, less than 10%. You can do the same exercise with organ response, even for the heart, but also for the kidney and other organs that has been covered in the morning. You have also to remind that AL amyloidosis and myeloma are not the same disease. Of course, we explained that in the morning. The tumor burden is not the same, and that means that maybe long-term treatment strategy will not be applicable in AL amyloidosis. But we also explained that it's very important to have the better and rapid response, and thus risk-adapted therapy based on the disease characteristic and patient characteristic will be of first importance. And then it's also important to recognize, it has also been covered this morning, that we should apply an aggressive follow-up in order to change on therapy if the patient doesn't achieve a very good response. So at the moment, the only current therapy for AL amyloidosis focuses on the suppression of the light chain produced by the plasma cell clone. So that means that we cannot have treatment that targets the aggregates inside the bloodstream or remove the deposits in organs and tissue. So the treatment that has revolutionized the management of amyloidosis patients is the Andromeda study with the DARA-CBORD treatment. Of note, this treatment was not foreseen for patients with class 3B AL amyloidosis, as well as patients with glomerular filtration rate below 20 milliliters per minute. But anyway, we can appreciate the overall hematologic response that was quite very high. Even VGPR or better was around 80%, better than the VGPR achieved with VCD, but the major impact of adding daratumumab to VCD was the fact that, as you can see on the right part of the slides, the decrease in the free light chain is quite very rapid, and in addition, you reach a level below the threshold, thus achieving a very good response. And that translates in organ response that, as you can see on the left part of this slide, is twice higher in terms of cardiac response and renal response when you add daratumumab to CBORD. In terms of PFS, also a better improvement without any doubt. And as you know, this combination is the only one approved by FDA so far. It's reimbursed in many countries, as well in Belgium since November 2023. But unfortunately, you clearly see that not all patients will achieve CR, and in addition, the initial mortality is in effect whatever the treatment you give. That means that there's still place for improvement. Why is it so? It's probably so because a patient with a very severe cardiac involvement will still die of the disease, not because they do not respond to therapy, but also because the organ response takes time. And that was also said in the morning. As you can see, the time from treatment initiation to initial organ response for cardiac is around 9 months, for kidney around 6 months. So how can we improve? But it was also covered in the morning for patients with a stage 3B. It's better, there are some study with VCD, but the best is probably to use daratumumab monotherapy. It will produce a very rapid decrease of the free light chains, and in most patients will help to pass the difficult period of the early months. Another way to do it is probably to use antifibrillary antibodies, but as you know, those drugs are only on investigation so far. There is certainly a rationale to combine chemotherapy, DARA-VCD, and antifibrillary therapy, because then you will not only act on the plasma cell clone, but also try to remove the fibrils already in the tissue. So there are two different medications. I will not pass too much time about that because I think the next speaker will cover that topic. The first time is KL101. It targets the fibril and help to phagocyte those fibrils later on. There are two phase 3 studies, one in stage 3A and another one in stage 3B that are, I think, have completed their accrual. I do not sure, but somebody will tell. And the other one is NEO D101. We not only act on soluble light chain aggregate, but also remove amyloid deposits by a macrophage. And there is also the AFFIRM-AL phase 3 study running. Well, there are certainly other targets that can be explored in patients who do not respond quite enough. We spoke in the morning about IMiDs, and particularly pomalidomide, but the other targets can be BCLA2 with venetoclax, or the BCMA receptor on the surface of plasma cells with both antibody drug conjugate, bispecific, or maybe later on CAR-T. So you saw this picture with venetoclax that induced high rate of response in translocation 11-14 AL patient, very high VGPR-CR rate compared to the patient who do not have a translocation 11-14. This cartoon shows you the effect of belantamab, and the other part of the cartoon, the usage of BCMA teclistamab in AL amyloidosis. Well, there is a publication that was presented early on in the Society of Cytogenetic and I do not remember exactly, but it was also present during ESA. We clearly see the number of patients who achieve a CR, that is the blue lines. Even there was some death probably related to COVID. And then we cannot say we will treat amyloidosis patient without speaking about supportive care. And it is of major importance to recall that we should have a multidisciplinary approach, and all the physicians, the different organ specialists and nurses and so on are involved in the management of those patients. Just a word about some special situation like IgM-related amyloidosis. It's important to think about the presence or not of the MID D88 mutation to know if we have really a Waldenström type disease that will be more treated like lymphoma with rituximab and bendamustine or eventually cyclophosphamide. And then I will finish with this cartoon, a part with biopsy typing and staging. As it was already said, even if we have a wonderful treatment with Darasibordi, it's important to assess very early the response of the patient and to switch therapy early if we do not have the goal of complete response of VGPR at least. There is a little room left for transplantation. It has already discussed as well. So prompt initiation of a highly active anti-amyloid regimen is critical for the patient since cardiac involvement is the main determinant of outcome. Darasibordi is the new frontline standard of care, and there are other promising target agents. And that allows us to be optimistic in that disease. You clearly see here the 5-year overall survival evolution over year, but still we have to recognize that in stage 3A and stage 3B, we still have progress to make. And I will finish with this cartoon that was presented by Professor Geertz from Mayo Clinic at the AHA meeting in 2017, showing that in the presence of NeoD001, macrophages were able to eat the amyloidose deposit. And here there is some work that are not published, made in the lab of Suzanne Lenz, showing that they are preparing a CAR, but not a CAR-T, it's a CAR macrophage that will be able also to phagocyte the amyloid deposits. And I want to thank you for your kind attention. I want to thank the organizer for the invitation once more. And also I'm very grateful to Arnaud and Frank to the possibility to have access to their multidisciplinary session that occur every 15 days. It's a very big help for us in order to be able to manage amyloid patients, and it's also a security for patients to know that their file will be discussed with very high specialists of those diseases. Thank you, all of us.